Good morning, everyone. Welcome to Psychiatry Education Forum Academy's updates. And we have a new update. So, FDA has approved this first liquid non-stimulant medication for ADHD, and this is Clonidine XR. And this was just released actually on May 29th of this year. So Tris Pharma released this update that they have received the FDA approval for this medication. They're calling it Onyda XR. So as you know that there are stimulant class of medicine for ADHD and non-stimulant. And in the non-stimulant class, we have this class called alpha 2A agonist. And in that, we have Guanfacine and Clonidine. Before this approval, Guanfacine was the only one with the XR formulation. Now we have Clonidine XR. But we don't have any liquid approved medication in a non-stimulant class. So this is a big news, I should say, and let me know how you feel about it. I know for child and adolescent psychiatrists, this is big news, especially for kids who have difficulty swallowing. And I will discuss this medication in various sections, ranging from FDA indication to mechanism of action. And I will compare here Guanfacine with Clonidine, and then we'll go over dosing, tapering, conversion, administration instructions, warning, precautions, adverse event, and drug interaction. So friends, I am Dr. Harvinder Singh, creator of Psychiatry Education Forum Academy. And I want to emphasize that I have no disclosures in terms of any financial ties with this pharmaceutical company or with any other as of now. So no disclosure from my side. And I will begin with FDA indication, but friends, please post your comments during this presentation. If you have any questions, or not even questions, if you have any inputs or your experience or your views, post your comments on that. I will try to look at them while I'm presenting, but if I'm not able to, I will reply back after I'm done with the presentation. So let's talk about it. I will try my best not to make this a long video, but the FDA indication for Clonidine XR is ADHD for age 6 and above. And this is approved as monotherapy and as an adjunct to stimulants, right? Many times we use stimulant first, but not every patient responds well to stimulants in terms of side effect profile, like tachycardia, blood pressure concerns, in terms of high blood pressure, appetite concerns. So non-stimulant class do play a very big role with that. Now, in terms of mechanism of action, as I was saying, we have two alpha agonists here, Guanfacine and Clonidine. So for our Academy members, we have a separate chapter on Guanfacine XR for ADHD. Please watch that for more details. But how these medications work is they work on the alpha receptors. But there are many alpha receptors, alpha 2A, alpha 2B, alpha 2C, and Guanfacine and Clonidine works primarily on alpha 2A. And alpha 2A is known to be a mediator of the impact of norepinephrine on prefrontal cortex. And we know prefrontal cortex controls our inattention, hyperactivity, impulsivity. I'll talk about that in a minute. But Clonidine also works on the other one, alpha 2B, alpha 2C, imidazoline. Alpha 2B more implicated with sedation, imidazoline more implicated with sedation and hypotension. So theoretically, Clonidine has more risk of that. And so we need alpha 2A for the therapeutic benefit And it's also known that guanfacine is, I think, 15 to 60 times more selective for this than clonidine. So as of now, guanfacine makes sense. Guanfacine also comes in XR, so be mindful of that. But okay, I'll not talk about guanfacine right now. Please watch the other chapter we have on that. But moving forward, so let's talk about this mechanism on alpha 2A, how that translates. But before that, we need to know something about prefrontal cortex role. So we have dorsolateral prefrontal cortex, which regulates our attention and behavior. And then we have ventromedial prefrontal cortex, which regulates emotions. And studies have shown that in patients with ADHD, the prefrontal cortex get impacted. So they have shown that there is reduced prefrontal cortex gray matter, there are weaker prefrontal cortex connection, and there is altered prefrontal cortex function. So we need to target this improvement in the prefrontal cortex. And how Clonidine XR works is it stimulates alpha 2A receptor, right, that we talked about, mostly the postsynaptic one, and it's mainly in the PFC pyramidal cell, the dendritic spine or prefrontal cortex pyramidal cell. So it stimulates alpha 2A, which modulates the impact of norepinephrine on prefrontal cortex and thereby strengthen these weak connections. And if you want to go deeper on how it does that, is it inhibits cyclic AMP signaling, and then that closes the potassium channels, which strengthens these physiological connections. Now, so you can see the impact of the alpha 2A on the norepinephrine causing these improvement in functioning. That is how alpha 2A agonists work. So be mindful, it's not alpha 1, it's alpha 2A agonism, which is helping with these symptoms. Now, that was the mechanism of action. And this is the comparison that we just talked about. So you need alpha 2A. The other are more like side effect profile, but this is what we need right now. Now, let's talk about how to dose this medication right now. Now, it comes in only one dosing formulation. They only make 0.1 milligram tablets. So starting dose is 0.1 milligram, and this is a bedtime dose, friends. Not a morning dose, bedtime dose. Because I will talk about side effects in a few minutes, but sedation and somnolence, fatigue, that's one of the common side effects. So it's a bedtime dosing. This is an XR formulation. And we know XR is better than IR because XR prevents those peak related side effects. So the side effect risk is lower with XR formulation compared to IR. So starting dose is 0.1 milligram, and you can titrate this on a weekly basis by 0.1 milligram. So if response is not seen and there are no side effect concerns like blood pressure and others that we will talk about, you go to 0.2 milligram in a week at bedtime, and then 0.3 with the max dose of 0.4 milligram at bedtime. And the max dose is 0.4 because they have not studied this dose beyond 0.4 milligram for ADHD. But we all know that the dose more than that is used in hypertension management. But that is the reason why it's not recommended beyond 0.4. And they also say if you're combining this with stimulant class, then you need to adjust the dose of CNS stimulants depending on the clinical response to. So Onyda XR is the Clonidine XR. And let's say a patient is on higher dosing, showing no response. You don't stop it. You need to taper it. This is very, very clinically relevant. So you taper that by 0.1 milligram every 3 to 7 days, ideally weekly to be on a safer side to discontinuation. Because if a patient is on a higher dose and you suddenly discontinue it, there's a risk of rebound hypertension, which I will talk about in the end. Now, here, this is really important. So sudden discontinuation can cause rebound hypertension. And also, if a patient is on stimulant here, and then you suddenly stop the Clonidine XR, you can see, right, how that additive action can come from stimulant and cause rebound hypertension. And there are other things which I will talk about that you need to be mindful of. Now, there are 5 important instructions given by the manufacturer for this medication that you need to follow clearly, because this is not a pill. Actually, I think I was saying a pill when I was talking about dosing. It's a liquid formulation. So you need to follow some guidelines on how to give it. So let me move my picture a little bit up so that you can see this more clearly. Okay, let me move it here for now. So they provide an oral dispenser, dosing dispenser. This is not the picture, like the right picture. This is the one that I found, but they will give you like to dose the dispenser and a bottle adapter. You need to use that. And you need to ensure that this adapter that they're giving you is firmly inserted into the bottle before first use, and then you keep it there. So you keep the adapter in place for the duration of the use of that bottle. And before you give this medication to your patient, and I think this is something we need to educate parents for kids, that you need to gently shake with smooth up and down motion to avoid any foaming. So very smoothly for 10 seconds. 10 seconds is the rule before giving it, by measuring that dosing dispenser. And once that medicine is opened, that bottle is open, and if there is still some medicine left, after 60 days, you need to discard that. So guideline says don't go beyond 60 days with this one. So these are basic instructions you need to keep in mind with this liquid formulation. Now, let me move my picture to here. So how to switch if a patient is on Clonidine IR? How can you switch? The first thing is you don't do a direct dose conversion. Like somebody's on 0.3, you don't jump to 0.3 of XR. Big no with that. You need to stop the IR and do the titration like 0.1, 0.2, 0.3, like that on a weekly basis. You do not substitute on a milligram to milligram basis. Please be very mindful of that. The risk is too high with direct conversion. And now let's talk about some warnings and precautions with this medication. The most important is the impact on blood pressure and heart rate. So risk of hypotension, bradycardia, and syncope is there. And it's a dose dependent thing. Like as the dose goes up, risk goes up. So you need to monitor heart rate and blood pressure before starting, with each dose increase, and even periodically while a patient is on treatment. So you need to titrate it more slowly, they're recommending. Now, titration is weekly right now, right? But they have not specifically mentioned what slowly means, but it's definitely more than weekly titration for this comorbidities. First is if a patient has history of hypotension, you don't go up faster. Patient with history of heart block, because there is a second side effect which I will talk about where this will play a role as well. History of heart blocks, bradycardia, right, for obvious reason, cardiovascular diseases, cerebrovascular diseases, and history of chronic renal failure. So it applies more like in elderly population, not in children, but be mindful of these things. You don't titrate faster with them. Now, you always avoid your patients to avoid getting dehydrated or overheated, especially in this weather right now with heat increasing in certain areas. It's a big education point for patients to be mindful of. Now, that's the number one warning thing. The number two is again related to heart. You look at cardiac conduction abnormalities with this one. So again, you will titrate slowly and monitor vital signs in patients who have cardiac conduction abnormalities, or they are on other sympatholytic drug. Clonidine is a sympatholytic drug. The other one in a psychiatric that we use is Precautions, right? So be mindful of those. Because they have found that when this was given together, there is high risk of them needing IV atropine or IV isoproterenol or even cardiac pacing. So risk is something that we cannot ignore with this. So please be mindful of that. And then we have this risk of sedation and somnolence. Very, very important thing with clonidine. And theoretically, the risk is more with clonidine compared to guanfacine because of the impact on the other alpha 2B and the imidazoline receptors. But they actually found this data in two studies. The first study was this 5-week study where the pediatric patients received a fixed dose monotherapy with Clonidine XR. And they found patients who got 0.4 milligram, 31% of those had sedation and somnolence. For 0.2, it was higher at 38%, placebo was low at 4%. But the second study was when they combined Clonidine XR with stimulants. Again, a 5-week study, but this was flexible dose. They found patients who are on both, right? Onyda XR, like Clonidine XR with stimulant, 19%, versus placebo with stimulant, 7%. So risk is definitely higher with monotherapy, but risk is still there with stimulant class. Now, you need to be very cautious when patient is on other centrally active depressants, right? For obvious reasons. When I talk about drug interaction, this is something it will come back again. But again, you need to caution your patients again, heavy machinery or equipment handling or driving. They need to assess first how they are responding to it, and definitely avoid alcohol or any other CNS depressants. And then is the risk of rebound hypertension that we talked initially with the taper plan. But let's talk about what are the clinical signs, symptoms that patient can present with that can raise your thinking for rebound hypertension. So clinical presentation is headaches, tachycardia like racing heart, nausea, flushing, warm feeling, brief lightheadedness, tightness in your chest, or feeling anxious. Now, you can see these pictures. I use this picture to bring things back to memory. Even when I'm doing this with my patients, it really helps. That's why I use these pictures to improve our understanding and our memory for these symptoms. But please keep an eye on these. And who is at risk? We talked about this. If you abruptly discontinue a high dose of clonidine, or if a patient is on stimulant and then you stop clonidine with that, right? That also increases the risk of hypertension with the stimulant doing that. And patient with GI illness like vomiting or inability to take medicine, that dehydration causing hypotension risk and then hypertension. And that's why that heating and warm weather also plays a role with that. And how can you avoid this risk? Very straightforward. Do the taper plan and monitor vitals with the taper. Now, let's end our session by talking about drug interactions now. So obviously the most important is antihypertensive because we don't want the additive hypotension risk with clonidine. So you always monitor blood pressure and heart rate and you adjust the dosages accordingly. And then is CNS depressant. We talked about this. Sedation can be potentiated. Clonidine causes sedation, somnolence, fatigue. So ideally, you should avoid it. And then drugs that impact sinus node function or AV node conduction, like digitalis, calcium channel blockers, and beta blockers. For us, beta blockers plays a role because we use that often for anxiety as well, like propranolol. So be mindful of that. It can make the bradycardia and risk of AV block worse. So they're recommending avoid it. Others were cautioned, this is a big no. And then tricyclic antidepressant, they're saying that it can increase blood pressure and counteract the hypotensive effect of clonidine. So you monitor blood pressure and adjust the dosage. It's not an avoid, just a caution right now. So friends, this was a brief overview of this new FDA approval for Clonidine XR. I hope this was helpful, clinically speaking. And I will post this in our blog post as well. Please go to psychiatryeducationforum.com/clonidine-XR to learn more details. And if you're interested in learning more, please join our Psychiatry Education Forum Academy. But thanks again for listening to me. You all take care and bye for now. Thank you again.